Welcome back. We will now follow with our scientific program with session number 3 about the importance of data governance on the implementation of value in health. We will have Manny Stiliado, founder and co-lead at Health Outcomes Observatory and vice president of the Data Science Institute at Takeda, and Thomas Metcalfe, head of Healthcare System Partnership Cluster Medical Affairs, Rouge, virtually presenting the latest findings on this topic.
So what we will be discussing with you today, or what we'll be presenting, is a public-private partnership that started 2.5 years ago when we received the grant from the European Commission. But the thinking on how to create this actually had started even earlier, or I would say a couple of years earlier. And from the very beginning, Tom and myself started thinking on what would be the right way to actually make value-based healthcare really happen. So as you all know, and you know this very well, that the healthcare spending is under extreme pressure, and as the OECD reports show, 20% of this healthcare expenditure is actually wasted. Also, one of the fundamental drivers of our thinking has been that the patient voice is not being heard by providers, payers, and regulators. Tom likes comparing this, and he will tell you more later, to the Babel Tower. So patients may actually be giving their input, but if that's not standardized, then it becomes noise. And when they increase the volume of this noise, then not only they're not being heard, but they may even annoy. So giving patients the possibility to structure their voice and make it a voice, give them, and therefore being able to create evidence about what's happening to them, it's critical in order to create true empowerment. And then the third part that we've identified as a problem is the lack of trust and incentives in sharing health data, which means as a result that we have very limited ability as a society to harness the potential of digital technologies and therefore accelerate both research and development in life science, but also create the evidence of value for innovation. So exactly which type of healthcare interventions should be rewarded and prioritized. So these being the problems, what we thought we put in place as a potential solution is first to standardize the PRO measurements in order to be able to create an evidence-based measurement of the burden of the disease, and in that way improve the healthcare efficiency. And the way we thought we need to do that is by actually equipping patients with the tools to measure the outcomes in a standardized way. I'm sometimes, often a little bit jokingly, I call this the eye care of healthcare, because a lot of people, when we explain to them what we are doing in this project, they know it and they see it makes a lot of sense. It would be wonderful if we had patient outcomes, standardized patient outcomes, longitudinal standardized patient outcomes on a big scale, but that's so difficult and it's so expensive. And the reality is that it's not easy. We are here to confirm that, but maybe if one looks at it from a different perspective, from a perspective where we share the work with the patients and we help the patients to measure their outcomes, so they do some of this work, then we can actually reduce the difficulty, the complexity, or the cost for making this happen. And of course, the third part of our solution is around creating an ethical framework around the data governance. And I'll come back to that, because as I said from the beginning, we thought the only way that we can make this happen is if we create trust in the way the data is being handled, so that the data can be generated in big numbers. So we had this idea, we created this proposal. We asked the European Commission, or IMI, the Innovative Medicines Initiative, to support us. They did, they said they would support us, and that went into public tender, and we had a number of public partners who created a consortium, responded to our tender, and created the consortium together with us to make this happen. So as you can see here, we have some very well respected, some of the leading hospitals around Europe who joined forces together with us to make this happen. So it's a number of hospitals, as well as public sector institutions, a number of pharmaceutical companies, and medical devices. Medtronic is one of our partners, as well as a number of public sector entities who actually joined us, and some of them later on, because they found that what we're trying to do is worth supporting it. So what it is that we are doing? So we have spent a lot of time thinking that to make this work, we need to really work on the governance of that. So we are actually creating, or already created, independent legal entities in the countries that are the first countries of implementation of the observatory. So this is Austria, Germany, Netherlands, and Spain. And these independent legal entities come together in what we call the Pan-European Observatory, which is in the process of being set up and will be set up in Denmark, with the partnership of the Danish regulator, as well as the Danish Health Data Agency, as well as the support of the Dutch HTA agency. It's important to mention also that we have the HTA perspective in our as the HTA perspective in our work. So these national observatories do a number of things. First of all, they identify altogether in alignment what should be measured. So the standardized outcomes that will be measured. We are not a standardization organization, so we are in no way competing with ICHOM. To the contrary, we've signed a collaboration agreement with ICHOM. Our focus is the possibility to implement the standards in a pragmatic way, and in particularly the PRO part, because we are thinking that one should be able to use the PROs as a common language between patients and clinicians, and therefore it needs to be implementable in routine clinical practice. So the observatories together, in the context also of the Pan-European Observatory, which is the association of the observatories, their focus is to identify these PROs and the clinical outcomes and the PROs that will be used in a consistent way in all countries. The second thing that the observatories are doing is that they will be working with a number of technology partners, and Tom will explain a little bit more about that, in order to give patients the possibility to measure their outcomes, as I said, in a standardized way, and they will be the place where this data will be aggregated. There will be access to the data to all bona fide researchers, subject, of course, to an ethical approval. The disease we start with is IBD, lung cancer, and breast cancer, as well as diabetes. And the countries have been chosen, if you will, a little bit arbitrarily, but the number is not exhaustive. Now, the important thing to stress here is the governance we're putting in place. So we've said from the beginning, what we are doing is we're creating an ecosystem, which we want to call it a network of trust. So in order to create a network of trust, we said that in every observatory, there needs to be a board that represents all the stakeholders who are part of the healthcare ecosystem. So that is the patients, first and foremost, is the healthcare professionals, the regulators or the HTA agencies, science or society, and this is on purpose a little bit vague, because depending on the country, one needs a different type of stakeholder there. So in some countries, it's the ministry. In some other countries, maybe the scientific societies, as well as the private sector, because we also said that for these observatories to remain sustainable, they need to have a business model. These are non-for-profit entities. They're not there to make money. And the whole idea of the observatories is that we look at the data as an essential resource. That's why we called it H2O, water, because the thinking is nobody should derive power from the data. The data is there for any bona fide researcher to get insights, and researchers, public and private sector, should compete with each other on the quality of their insights. but not on the control of the data. So this is why we need to have this multi-stakeholder boards that will be the trustees, if you would, of what is known in some countries as a data trust. These boards will be are appointing a managing director as well as a chief ethical officer who is independent and reports to the board, does not report to the managing director. And of course, the managing director will have to potentially bring in additional staff as needed. Now, the Pan-European Observatory, which is the association of this observatory since being set up in Denmark, is where the decisions are being made to ensure consistency in outcome measurements, to ensure interoperability, and ensure the financial sustainability of the whole ecosystem. The Pan-European Observatory, and that is, as I said, an association. However, it's an association of the national observatories, and altogether they have 60% of the votes. 20% of the votes go to patient organizations, and 20% of the votes goes to the public sector. And again, these are three different constituencies, as we call them, and there's been a lot of thinking going into that to make sure that we balance all the various interests and we create, as I said earlier, an ecosystem based on trust. So maybe Tom now will tell us a little bit more about how we also create the digital ecosystem that will actually support this. Tom?
Thank you, Minnie. Do you want to click one back up? Sorry,
Yes.
Are you in control? Yeah.
I am in control.
Great. Yeah. So, I mean, I think when you think about what Minnie's just presented us, which, you know, she's had a big focus on the governance approach to this, we also need a robust set of technologies to enable this, to enable the data flows, to enable the collection of data from patients, to enable the data to be integrated into a core outcome set between the patient-reported outcomes and the clinical reported outcomes, and also a robust environment for hosting this data and for ensuring that we manage the data in the way that our stakeholders, particularly the patients, is compliant with their wishes and with the underlying consent that they provide. We thought initially in the early stages of this project that it might be sensible for us to build our own technology, but when we reflected on this and we looked at what would be required to do that, and also what was already out there in the environment, we realized that building this ourselves would neither be a sensible use of public funds, but it also wouldn't enable the sort of ecosystem that we'd like to build, which is one where we leverage existing technologies really effectively to enable the governance model that Minnie has laid out. So what we decided to do was to recruit technical partners who are already in this field, active in this field, and to work together with us to enable these elements. So the elements that we want to do is to ensure that we can have data flow safely and efficiently across the H2O ecosystem according to the established rules, to the governance rules. And to enable this, we see that we will need a backend provider or a data repository who can ensure the smooth running of the data infrastructure and to orchestrate the data matching and data linkage. And then we also need a set of patient-facing technical partners. And from that extent, as I explained, we won't be designing an H2O app. We've decided to work together with existing patient-facing applications partnering with experts who have specialist experience in this field, and integrating our core outcome sets into the apps so that these can be deployed effectively in the healthcare systems that we're working in. If you go to the next slide, Manny. And this is sort of the high level architecture which we've laid out for this. So if you look at this on the patient side, what we want to do is to ensure that this is fully in line with empowering patients, and that this is essentially a consent-driven interaction between patients and the observatories, that we have a dynamic consent environment so that patients can supply their consent for the purposes which the observatory has, but they can also appoint which caregivers have access to their patient-reported outcomes data, and that they also get access to their own, essentially their own core data set fed back to them, so that they can see their own data and that they can compare themselves to patients like them. So this is essentially the functionality which we're building on the patient side. And within the observatory, as you can see, we've put together an architecture which will allow us to abstract clinical data from EHR systems, to link this effectively with the patient-reported outcomes, to then develop a layer which is an anonymized layer within the observatories, which gives us the summary statistics for this. And for those summary statistics to be aggregated at the first of all at the European Observatory level, so that the European Observatory has a view of all of the aggregated data which is available across the H2O ecosystem, but then also gives researchers, whether they're in the public sector or private sector, whether they have a role as within a provider or more as a health authority, access to the data in, as many's described, in a trusted research environment. So these researchers will be will have to specify the purpose for which they're using this data, and they will essentially be accredited researchers, giving them access to the H2O data. And I think Manny's also laid out to you that particularly the private sector researchers will pay for the access to this data, and this will supply the revenue streams which are going to be required to make this project sustainable over time. So if you go to the next slide for me. In the way we've thought about this, this is this has a build. So I mean, I think maybe you can go through the builds. Yeah, that's so great. We've got all of these actors which are being supported by the data flow enabler, starting on the left-hand side with the patient information, and which is also connected to a patient consent and identification. For them, or us able to construct a safe environment for personally identifiable data with this environment, to have an app which is then provided, as I said, by technical partners, which is the patient-facing app and for collecting the patient data. As I said, we'll also have a functionality which will allow us to abstract clinical data from hospital systems, to integrate that into a core outcome set, for this to be then integrated into various data packages, clinical data, PRO data, and combined data, and then for this to be made available, in this analogy, as with a sorting plant, to enable us to construct data sets which are anonymized longitudinal data sets, for these to be made available to those trusted research partners for analytics purposes. So this is what we're in the process of constructing. As I said, building an ecosystem together with technical partners who we want to have a dynamic set of technical partners so that we can build beyond the original set of markets or countries that we're working with, and also beyond the three primary indications we're working with, so that this becomes a scalable model over time, covering multiple markets and multiple indications. If you go to the next slide for me, Manny. So this is the sort of, very high level, it'll be quite similar to this, the patient agreement which we're developing, which, as I said, will ensure that the use of the data and the access to the data is all driven by patient choice, patient preferences, and is essentially consent driven. And if you go to the next one for me, Manny. So this is what we see as being at the core of this, that the standardized core outcome sets, obviously with a very strong underpinning of patient-reported outcomes, we see this as being a powerful driver of innovation and sustainability, helping healthcare systems optimize their care delivery through achieving better outcomes, by empowering patients to have richer interactions with their healthcare providers because they have their outcomes data available, leading to more innovation in life sciences, where we have, again, a systematic collection of standardized structured PROs and paired with clinical outcomes data to provide insights into standards of care, reveal patients' unmet need, and broadly advance scientific knowledge. And then lastly, with healthcare companies, so that, again, the standardized PROs paired with those clinical outcomes can be a new window into the patient experience and patient outcomes, allowing better business decisions to meet patient unmet needs, but also to allow the evidence generation to robustly assess effectiveness of various interventions. If you go, I think that was the last slide. So sorry, this is the I think the summary slide, so that we're working across the community to build a consensus in those standardized outcome sets and the PROs, that we have an expanding multi-stakeholder model of governance for health data, which we believe is the path to creating a trusted environment to unleash the power of health data. And as I said, it's designed to scale to other diseases and other geographies, so that we can leverage this, essentially this proof of concept which we're trying to develop within the project, and expand across Europe and further into the world. And I think that was our last slide, Manny.
Correct.
So
yes, thank you.
Thanks for your attention.
Thank you, everyone. Thank you, Manny Stiliadou and Thomas Metcalfe. And now we will follow with session number 4.